Okay, so welcome to this ankle and foot examination. Got Jonathan helping us today. Is it okay if we examine your foot and ankle? Yeah. Okay, as with any lower limb examination, I generally like to start with a gait. So we just ask you to walk to the door and back. Just back and forwards, that's great. Okay, so again, you're just looking for posture, any sort of abnormality in gait, any antalgia, any obvious foot drop, or problems related to the ankle and foot. I then like to do a bit of a power screen. So if you just go up on your tiptoes for me, and then rock back on your heels. Again, if there's grossly normal power in with those tests, that's reassuring. If there's some abnormalities that can be looked at more closely later. You can then do some functional tests. So if you just do a squat for me, so both legs squat. So again, just looking at the movement of the ankle and the knees and the pelvis. There's reduced ankle dorsiflexion, and maybe some compensation in the lumbar spine, which is evident on the squat. Just stand on one leg for me. That's fine. And then just swap over. Okay. Again, that just gives you an idea of balance. There's a lot of proprioceptive information from the foot and ankle, and that can be progressed by asking the patient to stand on one leg with their eyes closed and then looking up towards the ceiling with the eyes closed. And that just challenges progressively the balance systems and proprioception. That's fine. And then you can do another functional test which is useful for pelvic control. So just do a single leg squat for me. Again, just looking for rotation of the knee and pelvic control there. That's good. Okay. So then you have a closer look at the feet. So again, looking for any deformity. Is there any obvious hallux valgus? Are there 5 toes on each foot? Are the feet flat? Is there any obvious swelling or effusion around the ankle joint? That's fine. Okay, and with the feet, I always like to clear the back, as radicular pain from the lower spine can give rise to ankle and foot pain. So I'll just get you to lie down there from the back. You simply do this with a straight leg raise, asking if there's any sciatic pain down the leg. Quickly examine the hip, so flexion, internal external rotation. And just repeat that both sides. Internal external rotation. Also knee extension and flexion. That's fine. You can then again assess power if need be, so just push away from me, pull up towards me. That's fine. Again, looking for any leg length discrepancy, feeling for pulses, grossly assessing sensation, and moving on to tendon reflexes if necessary. If I leave it, just get you to lie. To sit on the side of the neck for me. So again, we can look at the foot in more detail now. So looking at the range of movement. So again, we may have picked up clues from our screening already about movements around the ankle, but to looking further. So we're looking at gross movements around the ankle. So if you just point your toe for me, that's it. The dorsiflexion, and then bring up your toe for me, that's fine. And just toe in for me, so inversion, and outwards for me, inversion, that's fine. And again, if you could point your toe, large toe, big toe, and up with your big toe, that's fine. And just repeat that on the other side. Down, inversion, inversion, that's fine. And then you can go on to assess the power of these movements. So if you just push away from me, pull up towards me, push against my hand, show the back of my hand, that's fine. And then you can isolate the large toe, push against me, pull it towards me, that's fine. Okay, and then we can palpate. There's a lot of sort of bony structures of the lower limb which is good to examine. So if you start with the tibial spine, moving down here, that's fine. Feeling the calf body itself. Is there any swelling, deformity or masses within the calf? We'll look at the Achilles a little bit later, that's also can be pressed here. So medially we have the medial malleolus, deltoid ligament, the navicular bone, and the talar dome. Laterally, the fibular head, lateral malleolus, the ATFL, CFL, PTFL, perineal tendon in the base of fifth metatarsal. It's proximal to the ATFL as the syndesmosis tendon and ligament and membrane, which can be felt there, which can be disrupted in lateral ankle injury. That's fine. Okay, and then you can go on to some special tests around the ankle. So first of all, you can assess the syndesmosis, which we've already palpated. If there's any pressure there, you can perform a squeeze test. So lateral pressure on the tibia and fibula, applying pressure there may reproduce pain. You then want to assess the integrity of the ligaments around the ankle and general stability. First you can perform an anterior draw test. This involves bracing the shin and simply pulling with slight plantar flexion on the calcaneum. Pain or an obvious lack of endpoint is a positive finding, and that primarily assesses the integrity of the ATFL. That can be further assessed with the Taylor tilt test. So again, in slight plantar flexion, you're inverting the foot, and again, pain or lack of endpoint may indicate an ATFL problem. With the foot neutral and inversion, that's more of the TFL ligament, and with dorsiflexion and inversion, that's more of the posterior talofibular ligament. You can then move on, then you want to also assess medially the deltoid ligament. So that's assessed again with slight plantar flexion and inversion, and again, pain or lack of endpoint was a positive finding. You then want to move down to the calcaneum. So simply squeezing the calcaneum both sides, the squeeze test may indicate a stress fracture. Might also be tender in plantar fasciitis, particularly on the medial border. And then you want to assess the midfoot. So if there's any midfoot fractures, such as a Lisfranc fracture, this can be assessed with the midfoot torsion test. So isolating the calcaneum, grasping the forefoot and rotating, and seeing if that gives any pain or discomfort. A further test of the forefoot is to look for any Morton's neuroma. That can be often palpated between the metatarsal heads as a lump. And again, squeezing the fifth and first metatarsal can give an audible click or a palpable click, which is a Muller sign in Morton's neuroma. If there's tingling or discomfort over the medial aspect of the foot, this might indicate tarsal tunnel syndrome, and that can be propagated with tapping over the tarsal tunnel, and also with dorsiflexion and inversion, leading to tingling and numbness in the medial and forefoot. You can then go on to assessing the Achilles integrity. To do this, if we could just lie your supine, on your front. So if I just, again, you need the opportunity while the supine to have a look at the Achilles. So if I just, could you just go over to the bed? So just have the foot neutral there. So again, you just palpate the Achilles, feeling for any lumps, swelling, any discomfort. Both sides. If you bring both knees up into flexion and squeeze on the calf, this should, just relax there, this should produce plantar flexion. That should equal both sides, and that indicates an intact Achilles. If there's an Achilles rupture, then you'll lose that plantar flexion reflex. That's fine. If I just get you to lie on your front again, the back, sorry. Finally, it's worth mentioning the Otter ankle rules. So any tenderness in the medial lateral malleolus, basic fifth, or difficulty walking 3 steps is a good indication and a sensitive way to determine if you need a plain ankle X-ray. And that concludes the examination.